bacterial. And so, without much ado, let me start the session. I will be joined by two of my esteemed colleagues, Dr. Haq is there with me, who is a consultant urologist at Mahavir Cancer Sansthan in Patna. Along with him, Dr. Shashank is there, who is consultant urologist at the Medica Super Speciality Hospital. So I'll be joined with them, and then Dr. Arup Nath over there today. So the session would go, we'll have two case presentations right at the beginning. So cases would be discussed by Dr. Haq, and he will be presenting the case, and then he will be putting the questions to the students. Dr. Jaid from SCB Cuttack and Dr. Ishal Kumar Neniwal from SCB Cuttack, both are final year MCA students. They'll be taking up with the task of answering the questions that are being put to them, and followed by the cases, we will have operative demonstrations where I will be showing a video of an high inguinal orchidectomy, and Dr. Shashank is going to show very interesting videos about RPLND. Followed by that, sort of an OSCE scenarios where I'll have a few case scenarios to present, and we would wrap up with that. So with that short introduction, so let me invite Dr. Haq to start the case presentation. Dr. Haq will present, and Dr. Jaid from SCB, he will be the student responding to the case. Yes, so over to you, Dr. Haq.
Good morning, sir. Thank you for the asking me to present the case. This is for the first case of the testicular swelling to the Zaid Ahmed Khan. The patient presented with the complaint of his 23-year male, and he noticed a left testicular swelling 8 months back, which is insidious in onset, painless, and progressively increase in size. And is hello, and he is also complaining of the pain in the left flank for the 2 months. And there is mild to moderate intensity, which is gradually worsening in the pain. It is constant, dull-eating, non-radiating, and on and off.
Mute everybody excepting the speaker. Mute everybody excepting the moderator and the student speakers. Please.
Okay, sir. I am muting.
It is gradually worsening, dull-aching, and constant pain, and it is relieved spontaneously or taking some medication. It is not
associated with the nausea and vomiting.
Slides are not visible actually.
There is history of loss of weight and appetite for the past 2 months. There is no history of surgery and trauma. No history of chest pain, cough, hemoptysis, headache, and fever. No, it's Zaid Ahmed Khan. According to the history, first let me know why we are asking these all detailed history and what your suspicions.
A 23-year-old patient presenting with a testicular mass which has progressed in past 8 months. So for that testicular mass, we have various studies coming into mind, which can be hydrocele, progressive hydrocele, epidermoorchitis, sometimes because of trauma, hematocele, or very rarely as a testicular tumor. So in view to our DDs, we have been asking all these histories, and associated there has been left flank pain. So somewhere we are more of thinking in terms of maybe a testicular tumor with a retroperitoneal lymph node, maybe, or an epidermoorchitis with a referred pain to left inguinal region, which the patient is mimicking as a flank pain. So with respect to that, we are asking all these histories, and this history of weight loss and appetite loss. We are looking more towards of malignancy. That is why we are trying to derive history in pertinent to malignancy.
Okay. According to the, yes, sir.
I was just asking Jack, epidermoorchitis, he has told that it's a painless mass. Can you expect it to be a painless mass? Testicular mass?
Epidermolysis usually will present with pain and fever to start with, sir.
Okay.
Can we please mute Vishal and some others who are unmuted? And Faizul, you might be having double logins. The sound is echoing.
Dr. Huck, you need to.
Yes, sir. I get rectified. I just log in for. Hello.
Yeah.
Hello.
Yeah. Now I think it's better.
Yes.
Yeah. Now I think it's better. Dr. Huck, you can continue. You can share screen and start the
Yes, sir.
presentation.
You can see my screen, sir.
Hello.
Share करो.
Dr. Jayad, until Dr. Huck is doing that, I want to ask one question. In a painless testicular mass of C8 testis, can there be pain? What is the cause of a pain in a testicular mass?
If that mass is increasing in size in a very rapid space, so because of that, there can be areas of infarction in between the tumor that can cause pain in that. And occasionally, sometimes there's hemorrhage within the testicular tumor that may also lead down to pain.
Most likely hemorrhage and infarction that causes. So what did you like to do? What are the things you would like to do? What are the things you want?
Because we are on the history side, so I wanted to ask more about the swelling, whether this swelling has been persistent, presenting as a swelling, and progressively increasing as a swelling statement, or there has been any time that on taking medication by a local practitioner, or because of means like on prolonged lying down, means swelling changes its size. Or has been there any variation in size, so that I can rule out whether differential diagnosis. Then also I would like to.
Please hold on. I would like echo. Not a echo happen.
Yes, sir. It's not
I think
clear for me
any
also.
double logins need to be removed and everybody else.
I think somebody is using two input devices, so that is the reason why dual audio input is there. So now is it better? Yeah, I think it's better now. Yeah. So Dr. Huck, you want to continue?
Yeah.
Sir, the echo is still there. It's very difficult for me to understand the question.
Yes, we are still having the
Hello.
Yeah, hello, Dr. Huck. Dr. Huck, do you have a single login or do you have two logins? No. If it's one login, then there should not be any.
Background.
I think we've lost Dr. Huck. So can you unshare Dr. Huck? I have the cases with me, so I can also share it from my screen. Are you able to see the slides now, Jai?
No, sir, not
Not yet.
Acha, can you please send the slides so that we can share?
No, I have the slides with me, so I will be sharing now.
You can share also because all have sharing right.
I am going to start sharing.
Yes, sir, it's visible. Yes.
Okay.
It's visible.
Is it visible?
Yeah, now I think slides are visible.
Slides are visible. That echo issue is still pertaining.
Hello.
Yeah, hello.
May I change the slide, sir?
No, these slides have been shared by me, so you can ask me to change. So I will change.
Okay, okay, sir. Okay. Okay, okay. Thank you, sir.
Okay, you can continue. So this is the history. So we'll go to the exam. We'll go to the past history.
In the past history, sir, there is nothing significant. The patient don't have any comorbidity. And in the what the past history would you like to ask Dr. Zaid?
I would like to know if he underwent any surgery for like undescended testis or hernia surgery before, and at what age he underwent surgery for that. Because if you're looking for congenital hydrocele surgery done in the pediatric age group, there may be chances that it was associated with an undescended testis, which the patient may not be knowing for that. Also, whether any of his brother or his father has similar complaints of a testicular mass being diagnosed before. So these history I would like to know. Also for mothers regarding whether antenatally she was involved with some drugs or onto any hormonal therapy for that reason. These history I would like to know.
What would be the percentage of increased incidence in case of the undescended testis?
The risk factor for undescended testis is 4 to 6 times than compared to the normal population.
Okay. After correction, it would be
2 to 3 times.
2 to 3.
It decreases to the half as compared to non-surgical. Yeah.
Yes.
If it is in undescended testis and it is corrected after puberty, then how would be the risk factor?
That won't affect upon decreasing the risk factor for this testicular cancer. Sir.
Okay. And the patient doesn't have any in the personal history. There is he is mixed diet taker, and he is occasionally smoker. Bowel was regular and sleep is adequate. Now, next slide, sir. Now come to the examination. We have very crisp examination, and it is a patient is conscious at the time of examination. The patient was conscious, well oriented. He is having a mild pallor. There is no icterus. The chest was normal, no severe features. In the per abdomen, it is soft, non-tender, no definite numb palpable. In the scrotal examination, it is. I beg your pardon, sir. Prashant, sir.
Hello.
Hello.
Yes, Dr. Hag, please tell me.
Yeah, actually, this is the case. It is reversed. The case has been reversed. The Zayed Khan has been allotted 23-year male. Actually, this is the bilateral.
My case, there was a testicular lump with left side flank pain. So maybe somewhere.
No, actually, the numbering of the CA testis case is different. It is case 2 is actually the case 1.
Yeah, yeah. Yeah, yeah, it's fine, sir. Now the per abdominal examination, there is a mass of size 10 into 6 centimeter. It is palpable in left iliac fossa. It is firm, non-tender, fixed, margin are ill-defined, surface is smooth. It does not move with the respiration. Now next slide, sir. There is no nodes palpable in the inguinal region, and in digital rectal examination, there is nothing significant finding. This is the pictorial diagram of the same patient. Just elaborate the Dr. Zaid Ahmed Khan, what you are seeing in this.
I can see a left testicular mass, probably occupying the whole of scrotum, with this a bit.
Yeah.
In the second right image, I can see that the skin is shiny with, and the pelvis is deviated to the opposite side. And
yeah.
Apart from that, abdominal fullness I cannot appreciate in this image, sir.
Okay. Also comment upon the secondary sexual character. It is well developed.
Secondary
okay.
sexual
Because a hypogonadotrophic sometimes patient may present because of testicular mass. And in lateral view, can you appreciate anything?
As such, in these images, I can't appreciate any mass. But
okay. So let it consider the which I have explained. There is a lump in the left iliac fossa of size 10 into 8 centimeter. Yes. And now come to the first of the left testis. It is diffusely large and it is firm to hard, and the testicular shape is maintained, and its size is approximately 7 into 5 centimeter. The swelling is non-tender, and testicular sensation is lost. And get above the swelling is present, cuff impulse is absent, and left epididymis and cord are thickened, and it is non-tender, and scrotal skins are free over the testis. Now explain everything which has been explained in this PPT. Please let me know why you are asking all this question.
A left testis, which is means firm to hard. Usually we get a first diagnosis as a testicular tumor, and also with added finding that the sensations are not present. All more so proves our point. Get up the swelling, that means it's a totally scrotal swelling. So somewhere inguinal DD we have ruled out. Only thing left epidermis and spermatic cord thickened, that raises a question whether it's a chronic epidermolysis or maybe somewhere that spermatic cord has been involved with testicular tumor. That we have to look after.
Sometimes it is because of the patient is having also the abdominal mass. Because of the lymphatics, they get dilated, so maybe they thicken the spermatic cord you are getting, it is thickened.
Okay.
And the scrotal skin, it is free. So what is the significance of asking?
That means that the T stage is not T4. We can comment that.
Okay. And now come to the after the examination, we have also explained about the abdominal examination. Now come to the basic investigation, which is hemoglobin of the patient is 12, packed cell volume is 38, WBC count is 9,000, in which the neutrophils are normal, fasting blood sugar was normal. There is no other significant changes in urine routine and culture, and chest X-ray PAVU, it is within normal limit. Any other thing would you like to ask to do in this patient? Any further investigation? Instead of
first of all, I would like to ask for the ultrasound of scrotum, inguinal scrotal region, along with the abdomen and pelvis.
So what extra information you want from ultrasound? You have already done a physical examination. So
sir, testicular tumor, we are quite sure that somewhere it's a testicular tumor on the basis of the examination, but there's according to history, there's a large fixed iliac mass present in the iliac region. So I want to see whether it's a only single mass or there are multiple masses available which may not be palpable. And the patient was telling that he has left flank pain for past 2 months. So I want to rule out, see whether there's hydronephrosis may be a cause for that left flank pain. For that.
In addition to abdominal ultrasound, is there a role of scrotal high frequency ultrasound in this patient?
So we should get it for a completion rate, but the palpative findings are quite obvious looking towards the testicular tumor.
The contralateral testis with an ultrasound? Is it
Yes,
of
sir.
any?
We would like to rule out that there are a few chances that there may be a bilateral testicular involvement. So I would like to see the opposite testis also.
What is the risk of having intratubular germ cell neoplasia in situ in the contralateral testis?
The 5 to 9%.
Is it 5 to 9% in all the patients, or there are some high risk categories where the risk?
If suppose the patient has undescended testis, or the other side testis is atrophic on palpation, then that risk increases up to 36%.
Age?
And if the age is less than 40.
Which is in this patient?
23 years male, yes, sir.
Yeah. So again, he is also a high risk to have a increased risk of having GCNIS on the opposite side.
Yes.
What did you do? Suppose you find GCNIS on the opposite side. How do you manage it?
If we find GCNIS on the opposite side, then
just anything else on ultrasound which would indicate GCNIS?
As such, no finding.
If you see
microlithiasis in a general population is not suggestive of malignancy, but in this case, with the testicular tumor, then it becomes significant for that reason.
Yes. So if you have any of these 4 risk factors, undescended testis on the contralateral side, atrophy, age less than 40 years, or microlithiasis on ultrasound, then these patients is a higher risk of
Bilateral.
35% risk. But what would you like to do for that?
I couldn't. Some voices are coming. I couldn't get you on.
I was asking, what would you do for the opposite testis? Now that this is the high risk of having GCNIS.
Considering that the patient is young male of 23, I'd be telling him that there's very high probability that in 5 years there is a 50% risk, and 7 years 70% chance of developing tumor on the opposite side. So I would ask him that it's better to go for sperm preservation in case he wants fertility to be preserved, and then managing this testis with a radical orchidectomy, I may add on a radiotherapy of 20 degree to the opposite side. Sir.
Okay, fine. So yeah, Dr. Harp, we can continue.
Yes, sir. The next slide, sir. Now, the serum tumor markers of this patient is alpha fetoprotein is normal, beta HCG is also normal, and LDH is slightly raised. Any comment, Zad, according to this parameter?
Because alpha fetoprotein and beta HCG are normal, only LDH is raised. Somewhere, maybe we're looking towards a seminoma as the diagnosis with normal tumor markers. LDH just represents the burden of the tumor.
Yeah, but markers can definitely rule out NSDCP. Even in NSDCP, markers could be normal, right? But still, seminoma, it indicates that it could be seminoma. Okay.
Seminoma, yes.
So this is
now the USD.
Ultrasound, I can see heteroechoic testis with hypoechoic means eccentric lesion, maybe that may be epididymis. So the ultrasound features, because it is heteroechoic, it may be favoring a non-seminomatous germ cell tumor more for that reason.
There is hypoechoic 7 into 6 centimeter left intratesticular mass with internal vascularity on color Doppler. So when you are asking for the ultrasound, Doppler should be added because in same machine we can see the vascularity also. Yes. So in the now come to the CT scan. The CT, can you appreciate anything in this?
The top rightmost figure, it's showing a mass with measurements which I cannot rate for that reason, but there's a mass which is looking
How large is the mass? Can you make a guess about how large the mass is? You can see in the right corner.
Comparing it to the vertebral column, I can say it's somewhere around 5 cross 5 centimeters or more than that.
So that is what you need, right? How do you classify N1, N2, N3?
N1 is and means nodes less than 2 centimeters. N2 is 2 to 5 centimeters, and N3 is more than 5 centimeters.
Yeah. So that is the rough size classification. Also, multiplicity of nodes also matters, right? Yes. So, but in the size classification, it is less than 2, 2 to 5, and more than 5. So this with 5 centimeter, it's an N3 straight away.
N3, yes.
Okay. Can you go to the here? Here I think mass.
Next slide. Heterogeneous enhancing left retroperitoneal para-aortic nodal mass of size 9 into 5 into 6.4 into 6.2 centimeter with mild left HDUN and hydrouretronephrosis, and there is heterogeneously left testicular mass. It is 6.5 into 5.5 into 4.8 centimeter with normal appearing spermatic cord, and bilateral lung field also the CTO has been done with the lung field, so it is normal. Liver, spleen, and bilateral kidney was normal except hydrouretronephrosis on the left side. Bilateral normal excreting kidney, no ascites, and bone appears normal. Now, how will you proceed further, Dr. Zayed, with this finding?
With this finding, I would like to go for straight away radical orchidectomy, followed by then depending upon the report, I'll be offering him. First of all, I would like to stage the disease. For that, I would like to offer radical orchidectomy for the patient.
So in this case, you have done a radical inguinal orchidectomy and patient came out to be an NSGCT, non-seminomatous. It's basically mixed germ cell, which is the most common diagnosis, right? So, and it's a P3 lesion involving the spermatic cord. So now you have the abdominal image, you are seeing the spermatic cord involvement, mixed germ cell tumor. How will you go ahead?
So it's a P3 lesion with N3 nodes. So somewhere we are looking for a stage 3 disease. So for stage 3 disease, considering the large para-aortic mass, I would like to offer him induction chemotherapy for the patient, BP for 4 cycles. Sir.
Why BP 4 cycles? 3 cycles?
So stage 3.
Yeah, right.
Advanced tumor with BP with 3 cycles, sir, because IgCCG criteria, it is coming to means food based and STST.
In IG triple CG, it is in good intermediate good prognosis.
So it's coming in the good prognosis, sir.
It is coming in the good prognosis, right? So that's why this should be 3 cycles. That
will you not repeat the serum testicular marker post-operatively?
Sorry, sir. Yes, I would like to offer, get testicular markers again post-operatively. Yes.
How many days after the orchidectomy?
Usually, because T half of alpha fetoprotein is 5 to 7, so we'll be giving around 3 to 4 T half lives for that to reduce. So somewhere around 3 to 4 weeks time.
Already the markers like alpha fetoprotein and beta SCG is not raised preoperatively. Is there any significance of repeating the testicular marker postoperatively?
With the markers not raised,
only LDH is raised because you are not doing the retroperitoneal lymphadenectomy or removal of the mass. You are only removing the testis. So I don't think so that LDH will come down after removing the testis. So what would be the significance of doing if already it is a normal?
Only things are that as per guidelines, we need to look for the recent testicular marker levels within 2 to 3 weeks. So maybe if that orchidectomy and that has laid on to 2 to 3 weeks, so I would like to get a new markers level for that reason.
Made for a reason, so there has to be reason, not that just you're following guidelines. So the reason here is CA testis is a rapidly growing tumor. Even if you're waiting 1 month, there could be growth within that 1 month happening. That is why before starting chemotherapy and after orchidectomy, you should have a baseline serum tumor markers.
Baseline.
Right. So that is to establish the baseline, and it can grow. You may have a negative before orchidectomy, it may become positive after orchidectomy.
Okay.
Okay. So you would give induction chemotherapy BEP for 3 cycles, and then you would reassess the patient, and then would follow. I just have one last question for you before I go to the next one. Suppose in this same scenario, patient had only an abdominal mass without any testicular mass. So what would you do in that patient?
In that reason, I would like to see the ultrasound findings, because somewhere I'm looking for burned out testis. So if there's the fibrosis or means microlithiasis in that testis, I will be considering that side testicular tumor. I would still be going for radical inguinal orchidectomy.
Okay.
So let me stop share and start share with the next patient.
Why there is so much of echo? Nirmalu, please look into the fact why there is so much of echo.
So trying, sir.
Yeah. Dr. Huck, you can.
Yes, sir. No, good morning, Dr. Vishal.
Good morning, sir.
No, it's you. The patient came to you. He is a 45-year male. He noticed a bilateral testicular swelling, more on the right side, for the past 4 months, which is progressively increasing in the size. There is no history
Hello,
of pain.
I have a very small request. See to that all the students get opportunity in the case presentation. I mean, facing the examiner. Please look into this combination.
Yes, sir. Yes, sir. Yes, sir.
No history of change in the size of the swelling with respect to the posture or the time of the day. There is no history of pain, no history of fever, burning, installation. There is no history of loss of appetite and weight, no history of surgery and trauma. There is no history of chest pain, cough, hemoptysis, headache, jaundice, and abdominal distension. Now, Dr. Vishal, what's in your mind according to this history?
Sir, 45-year male with the complaint of bilateral testicular painless.
Just a minute. First, what you other thing will ask in this patient?
Sir, may any history of trauma?
No. You have to ask the either he is married or not, and he's completed his family or not. Chalo, move
okay,
on.
okay, sir. In the past.
Yeah. So with this history, what do you think, Dr. Vishal?
Sir, in 45-year male with the bilateral painless swelling may be suspected of the suspect of testicular mass until unless proven, along with maybe other differential diagnosis may be suspected in the bilateral epidermoorchitis. Or the sir, swelling may be not reducible, maybe hydrocele also be suspected, sir.
Okay. Can we go to the next one?
No. Yes, sir. In the past history, nothing significant is there. There is no history of diabetes mellitus, tuberculosis, and hypertension. And is having the personal history, mixed diet, and now come to the physical examination. Bowel was regular and sleep was adequate. At the time of examination, the patient was conscious, well-oriented, verbally following the commands, and mild pallor was there. There is no icterus. BP was normal. Chest and CVS was normal. And per abdomen, there is no significant finding. And digital rectal examination, there is no abnormality detected. In the scrotal examination, the right testis, there is 8 into 5 centimeter firm to hard mass. Overlying is free and get above the swelling is present. There is no cuff impulse. In the left testis, it is also enlarged. It is 4 into 3 centimeter into firm inconsistency. And there is also painless and get above the swelling is present. Size of the swelling does not decrease on line down. Why am we are asking this decreasing in the size on line down? Any significance?
Sir, maybe any suspected hernia, sir.
So get above the swelling is also
Present, sir.
Then
maybe
bilateral
sir,
swelling.
Sir, maybe a hydrocele, sir.
Maybe
But
other thing.
Sir, maybe, but consistency is the hard, firm to hard, and may sometime that in case of the CA testis, when testis along with the cord structure may be involvement, so get above swelling may be present, sir.
Okay. Sometimes varicocele, bilateral varicocele may be there and decreasing in patient
okay.
lying down.
Okay.
And there is no palpable spinal nodes.
Yes, sir.
Now come to the investigation. Now, what is in your mind according to the present history?
Still, sir, diagnosis, differential diagnosis same as either maybe carcinoma of testis or bilateral hydrocele, or maybe epidermoorchitis, or maybe varicocele, sir.
So if you still have doubt regarding whether it is a testicular mass or a hydrocele or epidermoorchitis, what would you do if you still not resolve your doubts on physical examination?
Sir, do sir after the complete general physical examination, and I will do some investigation to confirm my differential diagnosis.
If you are having the 3 DDs, you are saying hydrocele, CA testis, and varicocele. So how will you rule out if in the examination part without doing further investigation to rule out different scenarios? Like in hydrocele, you do the transillumination.
Transillumination test, sir. Okay, ji sir.
So it will rule out the hydrocele. Now your DD will be more concise.
More concise. Ji sir. Ji sir.
Now come to the investigation part. The hemoglobin is 10.5, counts is normal. The other parameters like urea, creatinine, sodium electrolytes were normal. And in urine routine, you are not getting any pus cells. So the infective etiology is you are getting little bit out, like epidermoorchitis. Urine culture,
yes, sir.
And chest X-ray is within normal limit. Now come to this other investigation. Would you like to ask is serum tumor markers? Now it is alpha fetoprotein is raised, beta HCG is normal, and LDH is raised. Now tell me what you are thinking now.
Along with sir, first in history, I will ask the complete family history, because the bilateral testicular swelling. So one thing should be asked in the history, any complete family history, or married or not married, sir, patient.
Okay. Okay.
How rare is it to have testicular tumors on both sides bilateral?
Sir, in case of the bilateral testicular swelling and testicular swelling and alpha peto serum tumor marker also raised, most probably there is the carcinoma of prostate in bilateral testis. When patient is young age and family history not completed, and patient want to further
No.
to see.
My question was how rare is bilaterality in CA testis? Anybody else can answer.
Sir, 2%.
Okay, so it is 2%. And of this
2%,
how synchronous presentation? Do you understand?
Sir, mostly. Yes, sir. Yes, sir. Sir, most of time the presentation in the bilateral testicular tumor are metachronous. Synchronous is the rare chance, sir. In 2% of bilateral testicular swelling.
Yeah, so synchronous is even less. It's only 0.5
Yes, sir.
to 1% of patients
But-
who are synchronous
Yes, sir.
by amplitude. Right. Okay.
Yes, sir.
Continue with the next.
No, this is the CT diagram of the abdominal pelvis of the same patient. Can you appreciate here anything?
Yes, sir. Is the right? This is the sir penile and scrotum past. The cursor move. The right side testicular swelling.
Hmm?
This is the left testis and swelling, sir.
In this picture, you can comment upon it. It is at least the right testis is large as compared to the left side,
Large to left
the
side.
mass is heterogeneous. So
Yes,
this
sir.
is the important the findings of heterogeneous mass in favor of more malignancy. What you are getting here? Cut section at
Yes,
the
sir.
lumbar vertebra.
Lumbar vertebra so along the left, sir, below the left renal hilum. This is the pre-aortic, sir, lymph node. Left pre-aortic, sir, lymph node. Sir, seen.
How large is the lymph node? They've written it there. 3.5 centimeters.
Around
35 mm they've written. So it's about 3.5 centimeters. Right? In that particular.
3.5 centimeters.
Yes, sir.
Heterogeneous enhancing retroperitoneal, para-aortic, inter-aortic caval, and para-caval lymph node mass. The largest one of size 6.6 into 5 into 4 centimeter. The cut section where the mass, the lymph node was large was not taken in this picture, but consider it as a 6 into 5 into 4. And both the testes are heterogeneous. The right side is large as compared to left side, and rest of the solid viscera and kidneys are normal. There is no ascites and bony window are normal. Now, what you are thinking, Dr. Vishal?
Sir, so most probably this case is the bilateral testicular swelling with the para-aortic, intra-aortic, and para-caval lymph node enlargement in this case, sir.
So now your diagnosis is C8 bilateral C8 testis with retroperitoneal lymph node.
Lymph node, yes, sir.
Okay, so according to the lymph node criteria, what would be the clinical staging for the lymph node?
Sir, the lymph node largest size 6 into 5, so stage 3, sir.
Stage 3. And if it would be the 3.5 as depicted in the diagram, then it would be?
Sir, in the N, sir, N2 to 5 to for N2B, sir.
N2.
N2. It is N2.
N2, sir.
Yeah.
Entry as per this report. Okay. So what did you like to do now? You have got the tumor markers that are elevated in the what range? Is it S0, S1, S2, S3? Tumor markers.
Sir, S1 range.
So it is
Alpha
S1.
pitoprotein LDS is raised, sir, S1 level, sir.
So do you do it now or do you do it after orchidectomy?
Sir, after orchidectomy. This is the pre-operative, sir, only for the for correlate after the orchidectomy whether it is statics or rise or decrease after the orchidectomy, sir.
So what orchidectomy?
So further, sir,
S staging should be done after orchidectomy.
Yes, sir.
Okay.
So you will do a bilateral high inguinal orchidectomy in this patient?
Sir, still if patient family history complete and the size in both testes in right side around 8 centimeter, in left side in 5 centimeter. So criteria of the partial orchidectomy not fit for in this case. If family history is complete.
What are the criteria for partial orchidectomy?
Sir, in partial orchidectomy is the polar growth size around less than 2 centimeter and the testicular swelling less than 30% of the testicular total testis volume, when the remaining tissue is no component of the ITGCN. These are the criteria of the partial testicular testis cells.
Yeah, if the remaining testis has ITGCN or GCNIs, then what would you do? Then would you not do partial?
Sir, No, sir. Then also do partial orchidectomy along with the given radiotherapy of the remaining field area, sir. Around 15 to 20 grays in dividing dose, sir.
Okay. So you would do, this patient is not a candidate for partial, you would do a bilateral radical inguinal orchidectomy.
Yes, sir. After patient explanation and if patient want to semen preservation, so along with the semen, before semen preservation and also given in history patient is failure. So, sir, after pre-anesthetic checkup, if patient willing to semen and semen preservation, so give the opportunity for semen preservation and then plan for bilateral high inguinal orchidectomy in this case.
Better to say it is sperm cryopreservation because
yes, sir.
The words
yes,
are very important.
In this
yes,
patient,
sir.
bilateral testicular mass, large ones, it is highly likely that he would be infertile. The infertility rates are as high as 40 to 50% in this patient.
Yes, sir. Yes, sir. Yes, sir.
If you do a semen analysis, most likely you would find that he has got agiospermia or
oligospermia.
Yeah.
Yes, sir.
But anyway, so you will have to offer him that, and if he has got any viable sperms, offer him semen cryopreservation before you take up chemotherapy, right?
Yes, sir. Yes,
After
sir.
inguinal orchidectomy with option of giving him testicular prosthesis if he so wants, then you would do after that, what would you do?
Sir, after orchidectomy, sir, again, sir, assess the patient with repeat serum tumor marker along with CCT abdomen and pelvis, sir.
So serum tumor marker did not show any appreciable decrease, and the radical orchidectomy specimen showed bilateral NSGCT again, because we told you that it was a heterogeneous mass. So it is again NSGCT.
Yes, sir. So, sir, in this case, sir, bilateral orchidectomy specimen, so NSGCT with CT scan, so, sir, N3 type of group of lymph node and tumor marker again S1 type. So this case is the clinical stage, sir, 2C, sir.
2C. So what would you do for?
So, sir, in this case, we offer the induction chemotherapy for this patient. If the lymph node size increase and IGCC criteria is intermediate or poor risk, then given 4 cycle, otherwise 3 cycle of BP induction chemotherapy is given, sir.
Is it IGCCG intermediate or poor risk?
Sir, in this case, sir, the serum tumor marker is S1 criteria. This is the good risk for IGCC criteria.
Okay, so good risk IGCCG. So you would offer him again, like the last patient, 3 cycles of BP, right? What would you do if the patient is
BP3, sir?
Yeah, if patient is if bleomycin is contraindicated, what would be the contraindications to bleomycin?
Sir, in case of the pulmonary fibrosis, pneumonitis, or in case of the pulmonary mets also. So in this case, sir, also do chest X-ray initially, and if chest X-ray or in abdomen mets when or in any chest symptoms, then do chest CT also, sir, before given the bleomycin.
So if bleomycin is contraindicated, what option do you have?
Sir, either given sir EP, sir, only etoposide and cisplatin, or given sir etoposide, ifosfamide, or cisplatin, sir.
So how many cycles of EP would you give?
Sir, EP cycle is sir 4 cycles.
Yeah, so BEP3 is equivalent to 4 cycles of EP. So if in any case bleomycin is contraindicated, you would contemplate EP 4 cycles, right?
4 cycles.
So,
yes, sir.
How will you see after giving the induction therapy?
Sir, after every cycle, again assess the patient along with CBC, renal function test, pulmonary function test, and serum tumor marker after each cycle, and
okay.
any sir.
And after you will you will see the tumor markers also.
Yes, sir.
What are the type of response after the induction chemotherapy? What are the different type of response?
Sir, either maybe complete response, tumor marker may completely decline.
So what
Either
do you,
maybe
Okay,
sir,
it's come to the norm.
what do you mean
yes
by
sir. Sir, tumor marker range in the N0 level, sorry, S0 level after induction chemotherapy. So maybe a complete response with the CCT abdomen done after 2 to 3 weeks after the completion of induction chemotherapy. So no any residual retroperitoneal mass seen. So in this case, the complete response may be seen.
So what do you mean by no
If it is
residual masses?
Sorry,
See,
sorry, sir.
size of the mass,
yeah, what
what
do you
would be the size
Le-
of the mass? Will you comment that it is non-significant?
less
That is
than 1 in case of NHGST, less than 1 centimeter, sir.
yeah, so if it is less than 1 centimeter with no serum tumor marker elevation, then it's a complete
Yes,
response. What other
complete response.
what are other responses?
Other responses maybe sir, tumor marker is still in an S0 level, but the size may be continuous rise more than 1 centimeter.
Okay.
Or
So
only or other possibility, other
Next.
possibility may only serum marker raise and residual tumor may be decreased less than 1 size.
then
Right. So in the case
And
of if you have residual retroperitoneal mass which is still large, although your serum tumor markers are fine, how will you proceed with the management?
sir, in this case, the primary orchidectomy specimen show a non-seminomatous germ cell tumor and serum tumor marker is in within normal limit along
Yes.
with the residual tumor more than 1 centimeter. So maybe possibility of the teratoma. Post chemotherapy retroperitoneal lymph node dissection will be given option in this patient, sir.
no,
Right.
there would be
So-
three possibilities.
Yes,
there would
yes,
be three
I'm coming to
possibility
that
of the
exactly.
residual.
What are the
Yes, sir. Yes, sir.
possibilities when you are doing a
Sir,
retroperitoneal lymph node dissection?
Sir, in this NSGCT, around 40% chance may be found the necrosis, 45% chance may be found teratoma, and 15% may be viable GCT.
Right. So, for example, you do a dissection of this retroperitoneal mass, and you get, say, a mixture of necrosis and teratoma. What next?
So we'll do, sir, retroperitoneal lymph node dissection.
No,
If
after
serum
that-
tumor marker is normal.
Yes.
Sorry, sir.
Yes, yes. Tumor markers are normal, and your retroperitoneal mass is showing a mixture of necrosis and some teratoma.
Teratoma. So, sir, after biopsy or after retroperitoneal lymph node dissection?
After RPLND.
Sir, after RPLND. So, sir, after complete RPLND, continue patient surveillance, sir, or follow-up, sir, patient.
And what if there are some foci of active tumor as well? NSGCT, say embryonal cell or whatever, some active GCT, NSGCT in the RPLND specimen.
if you find viable tumor, then what do you do?
Yes.
Sir, if found viable tumor, then another, sir, second line in chemotherapy given for 2 cycle of BEP, sir.
What is that? What is that chemotherapy called?
Sir, salvage.
Salvage chemotherapy. That is salvage
Right.
chemotherapy.
So adjuvant chemotherapy is of 2 types, and this is a type of adjuvant chemotherapy that you will be giving.
Yeah.
Right.
Yes. Yes.
Fine.
Sir. Yes, sir.
Yeah, continue.
Yeah.
Let it consider to be a seminomatous tumor. Then how will you proceed with the retroperitoneal mass?
Sir, in case of the seminomatous seminoma, so size, sir, in seminomatous tumor, when the size is more than 4 centimeter, and when related testis involvement, that means this is high risk group, or size more than 4 centimeter. So given the induction chemotherapy in same case, sir.
Okay, so what would be the possibilities after the induction chemotherapy? Is there is a residual mass? In case
Sir,
of
in seminoma, most of the residual mass, most probability is 90% around necrosis. Only 10 or less than 10% chance of the viable GCT, sir.
okay. So if there is a residual mass, then how will you proceed if it is a small residual mass like 2 centimeter or 1 centimeter?
So in case in primary orchidectomy, if seminoma present, then size less than 2 centimeters. So sir, nothing will do. Only observe, because of the in many of the around 50% of the seminoma case may resolve spontaneously around 1.5 years, sir. If size less than 3 centimeters.
Okay. So will you not see the serum tumor markers? Is
Sir,
there any role of the PET CT? Is there any role of the PET CT in this seminoma case?
Sir, after induction chemotherapy, when the residual tumor size more than 3 centimeters, so we'll offer the FDG PET scan.
PET scan. Then how will you proceed if it is positive or negative?
Sir, in case of the size more than 3 centimeter and FDG PET scan is positive, then maybe chance of the viable GCT, so given a second induction, second chemotherapy for this patient, sir. Second line chemotherapy.
Okay. Prashant sir.
Yeah, no. So I think we have ragged it enough. So let us now go on to the next part, which would be a video demonstration of an high inguinal orchidectomy. Arup was supposed to do this, but unfortunately he was not with us. So I will be putting up a video of an high inguinal orchidectomy. Right?
Yes, sir.
Is it?
Yes, sir. Yes, sir. Well appreciated, sir.
Cancer is the most common malignancy in adolescent and young adult males. It frequently presents at an advanced stage, but outcomes are excellent. Our patient is a 17-year-old Hispanic male who presented with abdominal pain, shortness of breath, and a left testicular mass. Testicular markers were all markedly elevated, and he is found to have widespread pulmonary metastatic disease and a solitary brain lesion. Because of his pulmonary compromise, he underwent initial treatment with chemotherapy, 2 cycles of VIP, and then returned for radical orchiectomy. The patient is placed in the supine position. Note that the penis is retracted out of the way. The external ring is palpated and the site is marked. An inguinal incision is then marked with a hockey stick extension to accommodate the large testicular tumor. The slope is gentle to reduce the risk of tissue ischemia at the corner. The incision is open, starting with a smaller incision until we can determine if the incision is sufficient for the size of the mass. Dissection is carried down into the subcutaneous tissues. At this point, we decide to extend our incision to accommodate the size of the mass. Dissection is continued until the external oblique fascia and the external ring are identified. The tissue overlying the spermatic cord is completely open to allow for easy delivery of the mass and testicle. The mass can be bluntly dissected away from the overlying skin. Note that there is no tethering tissue that would limit the delivery of the testicle. Here, the gubernaculum is incised with the aid of the surgeon's fingers, everting the scrotum to ensure there is no scrotal skin violation. Of note, this area is very vascular, and hemostasis is imperative as we dissect the mass away from the scrotal skin. Now the testicle and mass are free from the dartos of the scrotal wall. The external spermatic fascia and cremasteric fibers are incised in order to leave only the vessels and vas deferens free, so we can trace the cord back as high as possible. The cremasterics are further lifted off and traced proximally. Once the cord is freed from surrounding attachments, you will note that we have placed new drapes surrounding the incision. In addition, we will place a Buckwalter retractor with an 8-inch ring for optimal exposure. This allows surgeon and assistant to have their hands available to work rather than exposed. The external oblique fascia is opened, allowing us to continue to trace the cord proximally. Cremasteric fibers are further dissected away, and we can now identify the location of the internal ring. The Raysacker lab can be used bluntly at the posterior cord to help with entry into the retroperitoneum. At the right of the screen, a muscle movement confirming that we are dissecting away the cremasteric fibers. Again, bleeding is common when dissecting away these muscle layers, and hemostasis is critical. We can now clearly see retroperitoneal fat, indicating that we are proximal enough on the cord. peritoneum is also identified here. The cord is then separated into two sections with vas separated from the vessels. Each section is controlled with 3 Kelly clamps each, 2 proximally and 1 distally. The cut is made between the 2 proximal clamps and the distal clamp. Once the specimen is divided, but before being removed off the field, a silk is used to tie off the proximal end so pathology can identify the proximal margin of the specimen. We then further divide the vas until we can see the vas making its medial deviation, indicating that we are high enough into the retroperitoneum. A stick tie with O-vicryl is then placed either between the Kellys clamped on the vas or just proximal to both Kellys. An O-silk or 2O silk free tie is then tied proximally and the vas is replaced. In the same way, a vicryl stick tie and a silk free tie are placed proximally on the vessels for adequate hemostasis. 4O proline is used to tag the vessel stump. 2 clips are applied to the proline and further clips are applied to the tissue. The permanent proline suture can help identify the stump of the cord if you need to return for retroperitoneal lymph node dissection, and the clips are useful as they will be visible on imaging. You can also clearly see the iliac inguinal canal here as an indicator of how proximal we are on the cord. The stumps are now placed as high in the retroperitoneum as possible. You can see here that no remaining stump is visible. For closure, we first reapproximate the external oblique fascia, taking care to avoid entrapment of the ilioinguinal nerve. The remainder of the skin is closed in layers, and the procedure is concluded. In conclusion, careful management of surgical technique during radical orchiectomy can be useful to ensure the patients receive an oncologically sound operation.
Yeah, so that was the video. High inguinal occlusion. Now, for discussion of this, Dr. Ola, Dr. Vijay Ola, is he there with us? Anyway, so Dr. Vijay Ola was the resident who was supposed to be there. He is not there, so we'll discuss with others. So I just wanted to know what nerves are. Hello, Dr.
Yes, sir, I'm here only.
So what nerves, which nerve is able to get injured when you're doing this high inguinal occlusion?
Ilioinguinal nerve, sir.
So how do you preserve ilioinguinal nerves?
After incising cancerous carpus fascia and external oblique aponeurosis, we carefully separate the ilioinguinal nerve and then lift the cord from just the pubic tubercle and then do the dissection through the deep ring.
Yeah, so ilioinguinal nerve is closely adherent to the spermatic cord in the inguinal canal. You need to separate it from the spermatic cord and then preserve it. Also, take care that entrapment is not occurring when you are closing the external oblique aponeurosis at the end. What was the need to put non-observable suture and clips in the vascular stump in the end?
Sorry, sir. Can you repeat? I can't.
What was the need to put non-observable sutures and clips and metal clips on the vascular stump?
It will help in our further retroperitoneal lymph node dissection. We can easily identify the cords from the ligature like prolene or silk.
Okay. My last question was, why did they take care to ligate separately the cord and the remaining of ligate separately the vas and the remainder of the spermatic cord structures?
Because vas is not the part of standard retroperitoneal lymph node dissection, sir.
Yeah, so that is the reason. And other reason is whenever you tie a chordate structure along with other soft structure, there is a chance that it will slip out. And then there can be vascular catastrophe, bleeding can be there. That is why when you have a rigid structure, you should tie it separately and not along with the rest of the structures. So yeah, so I think the rest of the video was quite well explanatory. I do not see any other questions there. If you have any doubts, you can ask and we will answer. Otherwise, we'll move to the next part of the session.
Prashant, can I ask a small question?
Yes,
Dr.
Yeah, please.
I think in spite of taking a lot of precaution at times, this catastrophe takes place. How a surgeon should handle that catastrophe?
If it bleeds,
I mean the sleeping of ligature. In spite of giving two ligature, I have seen in my own eyes this has happened with one of my seniors while doing so. I like to know how they should, because they can also face it in their lifetime and in examination also. This is a very pet question. How will you handle the retrieve stump?
So the retreated stump needs to be
I think
explored.
students should answer. Students should answer. They should have the answering ability.
Dr. Ola, would you like to take up?
Yes, sir. We shall do some more dissection around deep ring, and we will in the inguinal lockedectomy we widen the deep ring. So if the cord retracts, then we have a chance to retrieve it from the widened deep ring.
The cord will retract. How will?
It's not so easy, Vijay. It is not so easy. There are means how to hold the structure. But
that I don't know, sir.
If you can answer, you please guide them, Prashant.
Yeah,
it will be better.
Like prevention is the best part. Like we said, we should make sure we're holding with it with one or two instruments at least. We take a tethering suture right at the beginning. Make sure we separate the vas deferens from the rest of the cord, like you told. And if it slips, in spite of all your precautions, you need to explode. You need to extend the incision. You need to get into the retroperitoneum to try to place it.
Yes.
But only option that we have.
You will have to reflect the peritoneum, and you will have to reach the retroperitoneum and take hold of the vessels very carefully at that side, because it is a retracted small remnant then. Okay. Thank you.
Thank you, sir.
Excuse me, sir. Excuse me.
Yes, you want to ask something, Jai?
Yes, sir. Sir, in cases that we are performing radical orchidectomy on the one side and we plan to do biopsy on the other side, so that biopsy is usually done in an open method, or is it a percutaneous? I had that doubt, sir.
You can do a percutaneous ultrasound guided biopsy, but it has to be in the high inguinal. It has to be high inguinal biopsy. You need to deliver the opposite testis again through an inguinal incision, and then you can do either a percutaneous ultrasound guided biopsy or an open biopsy. So that's up to you. But you should not do a transscrotal percutaneous biopsy.
Okay, sir. Thank you, sir.
The approach should be the inguinal. You keep the probe, if you are using ultrasound, keep the probe over the testis and look for the area where you are having the suspicion, then do a needle biopsy, or you can do the open.
Yeah, absolutely. I think we'll move to the next part, which is the RPLND demonstration. I am also looking forward to see this. Our excellent speaker, Dr. Shashank, is going to take us through RPLND. Yeah, Dr. Shashank, over to you.
Thank you, Dr. Nayak. Very good morning to everyone. So it has been a very enlightening discussion with the residents and all the great learned teachers. I'm sure there are a lot of very senior people in the audience. Talking about RPLND, so I've made a very small presentation where I've got 2 or 3 slides. This is for everyone, specifically for the residents. And I've put in some very, very relevant, important points that we have to be aware about while considering RPLND. And then I've put in 2 videos. So one is the classical open RPLND, which is basically the split and roll technique coming from the aorta, top to bottom. And then there's one interesting video from the Tata Memorial Center from Bombay, where they have approached the RPLND dissection from bottom to upwards. So I'll quickly run through both the videos. I'll just share my screen.
One question, sir. In case of the classical retroperitoneal lymph node dissection,
yes.
For the student, please elaborate, sir. What are the lymph node you will like to remove, sir?
Yes. Basically, it's the entire list of packets. So we'll put this question to the residents first. Let's go through the videos and then we'll put it for the residents. This is one of the questions that is asked.
Yes, sure.
Yes.
Sure, sir.
Is the slide visible?
Yes, sir. Yes, sir.
All right. So indications. This is a very important slide. The indications of an RPLND in stage 1 NSGCT. Optimal management can be surveillance, a primary RPLND, or a primary chemo BEP into 2. In cases of lymphovascular invasion or EC predominance, an active treatment is preferred. Surveillance is not preferred. And usually the recommended approach to RPLND is a full bilateral template with nerve sparing. This is the classical recommendation for RPLND. There are some scenarios where a modified template has been recommended. I'll come to that. I'd rather ask one of the students about what is the indication for doing a modified template. And in clinical stage 2A and B, there can be a role of primary RPLND or an induction chemo followed by primary RPLND, post-chemo RPLND. So these are the summarized indications for an RPLND. There are some terminologies which are very frequently used when we are discussing RPLND. So all of us, including the residents, should be very clear about the use of these terminologies. A primary RPLND refers to one which is done after orchiectomy without any other treatment done before. A post-chemotherapy RPLND, which is the most commonly encountered one, is the one which is done after induction chemotherapy. This is one that has been discussed a lot in our clinical scenarios today. The salvage post-chemotherapy RPLND is the one that is done after both an induction and salvage chemotherapy. So you've given a second round of salvage chemotherapy after which you're doing an RPLND. This is going to be a salvage post-chemotherapy RPLND. A desperation PCR-PLND is the one where there is elevated serum tumor markers. So this is a criteria for calling it a desperation PCR-PLND. It has been noted that the overall survival is poor in cases of desperation RPLND. It is usually recommended in a multimodality setting, in a team where a team discussion is done, and then you embark upon a desperation RPLND. Yes.
The serum tumor markers are elevated both after induction and then salvage.
Yes, exactly. That's right. The reoperative RPLND, which is rarely encountered, is one that has been done after a prior RPLND has been done. And resection of late relapse is defined as a relapse that occurs after more than 24 months after complete response from the primary chemo. So these are very clear-cut terminologies, and we should use them as it has been defined in our textbooks. All right, this is an important checklist that should be seen by any surgeon who's embarking upon RPLND. Number one, include the thorax always in addition to abdomen and pelvis. Number two, look for a retrocaval extension of that mass carefully. Number three, look for bleomycin toxicity. Number four, look for any vascular anomalies because you are going to be dissecting directly upon the great vessels. So any accessory renals, any retroaortic renal vein, these are things that you should know before entering the retroperitoneum. Number five, components of seminoma. Number six, a pre-op ureteric stent requirement. If there is any obstruction caused, should you put in a stent or not? And lastly, any thrombus present in the vena cava or in the gonadal veins. So these are a surgeon's checklist upon an RPLND. All right, preoperatively, these are 3 or 4 things that we have to talk about. Some of them have already been talked about by our residents in the various case discussions. I'm just summarizing them. There should be a CT scan available within 6 weeks of you doing an RPLND. Number 2, your serum tumor markers must be done within 7 to 10 days before surgery. It should not be your old serum tumor markers that you've done, say, 3 months ago. Number 3, sperm banking, always in the situation like our second case where the 45-year-old gentleman who was having bilateral tumors. So if you're doing a bilateral orchiectomy, and as Dr. Naik had also told that most of these patients are already azoospermic or oligozoospermic. So the consideration of sperm cryobanking should be considered and discussed with the patient in advance, as long as the patient is of a childbearing age. And a pulmonary function test, the adverse effects of bleomycin. All right, so these are the basic steps of the surgery. This is from Campbell. This is one of the most important pictures that you get as to how you approach RPLND. First of all, the patient is supine and the arms are wide out in a T. There's a midline incision that goes from the xiphoid below the umbilicus, usually goes up to 2 centimeters below the umbilicus. And you start incising from the tip of the cecum. So this is the place where you start incising the posterior peritoneum, and you take a plane between the mesentery and the retroperitoneal fat. This is the plane, and you go up to the medial end of the inferior mesenteric vein. This is your first incision that goes there. And then, of course, we go to the split and roll technique, where you make an incision on the anterior surface of the aorta. This is just below the renal vein, the level of the renal vein. And of course, you can go down up to the iliacs. Depending upon the location of the mass, your technique can differ. And the rolling is done in each direction so that you can take care of the inter-aortocaval nodes as well as on the para-aortic nodes on the left side. So you split the fascia or the posterior peritoneum in front of the great vessels, and you start rolling them on either sides, and make sure that you're using low energy diathermy. And in one of the techniques, which has been shown by the Tata Memorial video, they've used the backside of a 15 blade. So that was interesting that they could use the reverse side of a 15 blade to do these dissections as well. All right, the location of the sympathetic trunk is very important in view of the nerve sparing technique, which is now considered the standard of care as long as it is feasible, surgically feasible. So a lot is talked about the location of the sympathetic trunks, which go into the superior hypogastric plexus. And you try your best to preserve the L1, L2, L3 postganglionic sympathetic fibers. And you may need to divide the lumbar vessels, but preserve the nerves. These run very close to each other. And this is the part which is challenging when doing RP-LND. And in addition to that, there's always a chance of having a lot of lymphoria after the surgery. So generously, clips should be used to clamp any small vessels, any small lymphatics which come in the way, while making sure that you are preserving the nerves. This is a picture showing the bilateral nerve sparing technique. Very meticulously, each of these fibers have been preserved while making sure that the vessels are safe as well. All right. In the post-op, there are some very, very important clinical things that I wanted to outline for the students. Intraoperatively, you should make sure that you inspect the bowel in totality. This is a recommendation. You should inspect the bowel in totality to look for any inadvertent injury. The liver, pancreas, and spleen should also be examined. And you can usually allow orally clear liquids on the evening of surgery itself. Ambulation is mandatory from day one after surgery. You can take the drain out once the output is less than 100 mils in 24 hours. And usually in a good recovery, the discharge can be done from day 3 to day 5. So this was a summary of this whole operation in what to expect, what are the indications, what are the pre-op requisites, what are the important steps, and what do we see in the post-op. Let's go on to the video now. We'll come back to the complications later. Is the audio audible?
No, we're not getting the audio.
Okay, most of it is labeled, so I think it should not be a problem.
You can continue a running commentary.
Right. So that is the incision in the posterior peritoneum that we were talking about. Up to the ligament of Treats, the bowel is usually reflected upon the chest of the patient and covered with moist pads. This is the split that is being performed. So they're starting with the vena cava. This is very important. The limits of dissection. We'll take it up with some of the residents. This is the rolling. That's your level of dissection. Another rolling being performed for the intra-aortocaval package. this is one thing that we need to be aware of. So that's an alternate approach. If we're doing a left-sided only, we can start from the left white line of Tolt and reflect it towards the right. Right, we'll quickly look at another video. It is just an alternate approach going from bottom up. So that's defining your lateral boundary of dissection.
Now disconnected from iPad. Play from iPad.
That's the specimen coming out, a left para-aortic mass. That's the reverse side of the number 15 blade being used for dissection. This is the intra-aortocaval packet of nodes. So using clips to avoid post-operative lymphatic leakage and drainage. That's the prevertebral fascia, your deep level of dissection. Paracaval dissection up to the right ureter. So the finger, to make sure there's no retrocaval tissue being left behind. That's the gonadal. Up to the deep ring. that's the completion of the whole thing. That's how the bed should look like after you've done an adequate RPLND. I think with both these videos, it gets fairly clear to everyone that it's not that difficult a surgery because it's very less discussed and it's very less seen by all of us. So it appears to be a very challenging task, but with some degree of experience and performing it, I mean, it's just about having clarity on the anatomy of the retroperitoneum in that area. There's another little video about robotic one. So because that is becoming more popular now, I just wanted all the residents to have a quick look. There's a slight difference in the approach. So the incision is begun at the same level, the cecum, just beneath the cecum at the ileocecal junction. What they usually do is, once they've incised this layer, they use some straight needles to retract the small bowel, because retraction becomes a challenge in robotic approach, unlike the open approach. And that's the aorta and the IVC. So just for orientation, robot is docked from the left side. So that is the group of intra-aortocaval nodes that you need to take out. While you might have to clip a lot of smaller vessels there, the lumbars and all that. The magnified vision definitely helps in these scenarios. So in short, that is what I wanted to impress upon everyone. Coming back to the complications. So pulmonary complications after post-chemotherapy RPLND, and keeping in mind bleomycin. So ARDS is something that you need to be aware about. A post-op ileus is common because you're handling the bowel and keeping it out for such a long time, but that settles down normally. A lymphocyl, as we talked about, a lot of lymphatic dissection being done. So that can be prevented by meticulously applying clips or ligating channels. Chylous ascites is a complication. This can be usually avoided by not going suprahilar. So the level of resection is kept below the level of the renal vein. And the cisterna chyli is located a little bit above, just behind and above that level. So it may not be well defined in a lot of people. And a milky fluid with high in protein and high triglyceride level, if it is coming in the drain, that is suggestive of chylous ascites. And venous thromboembolism, like any other surgery, any prolonged surgery, we should take care of the VTE prophylaxis as well. So as told by one of the residents sometime earlier, this is important. The outcomes are three. Number one, fibrosis, seen in about 40% of cases. The long-term survival is more than 90%. Teratoma, about 45% of cases. Long-term survival approaches 90% in these as well. And viable GCT is seen in about 15% patients. These may need some adjuvant treatment, and the long-term survival drops down to 50 to 70%. All right. So that's about it. I think that's all that I wanted to share regarding RPLND. Dr. Naik, we can take some questions from the residents. Anything?
Yeah, can take some questions, and if you want to ask some question, Dr. Sumantra there.
Yes,
so
yes. All right. So I'll ask one question. Usually the standard of care for RPLND is a full template bilateral nerve sparing approach.
Right.
But there is an emerging popularity of modified template RPLND, or on the left or on the right, depending upon the location of the testicular malignancy. So what is the indication, or what are the criteria for choosing a modified template?
So the indications are mainly three. Number one, if the lymph node mass is less than 5 centimeter with no tumor markers are normal range, and if it is a IgCCCAG, good risk category.
Good or intermediate?
Good or
even intermediate is included in this.
Right.
All right. Very good. Excellent. And okay, what are the lymph node packets that you take in an RPLND?
So it's three main packets that we take. One is the right-sided paracaval packet. One is the inter-aortocaval packet, and the left-sided para-aortic packet.
Yes. Anything else?
We also take the gonadal vessels along with it.
Yes, the gonadal vessel up to the deep ring, and in some cases, if there is any visible lymph node enlargement, you can take the interiliac group as well, just beneath the bifurcation. Sometimes there'll be a well-defined packet there which you can pick up while doing an RPLND. All right. I think that's it. Anything, Dr. Naik, you can ask.
Yeah, no, I just wanted to ask, I have a question. So what are the various accessory procedures that sometimes you need to do with RPLND?
Yes, yes, that's it.
So the accessory procedures may be maybe the most common accessory procedure along with an RPLND is a nephrectomy. It is usually seen in cases of salvage post-chemotherapy surgeries. Other than that, vascular procedures involving resection and resection of the IVC or the aorta and replacing it with grafts is another accessory procedure. Other than that, hepatic resections are also sometimes necessary, and rarely bowel resections or associated organ resections may be necessary. Splenectomy is also an associated procedure involved in certain cases.
Okay. Any other
vascular reconstructions?
Yeah.
Yes, sir. Vascular reconstructions, if it may, both the IVC and the aorta may need reconstructions. Sir, I'm not very clear about the details regarding vascular reconstructions.
Right.
Just,
that's okay.
And one more question.
Yes, please go ahead.
How will you avoid how will you treat the chylous ascites if it would be there? What will you advise?
Sir, after diagnosing and confirming a chylous ascites with triglyceride and protein levels, I will have to put the patient on fat-free TPN, and octreotide. And sir, we have to wait for the chylous output to come down. Usually, conservative management procedures bail out. In the event of not responding to conservative management, we might need to re-explore. So, but that is in very rare cases.
Okay, one more thing is medium chain triglycerides. You have to advise the medium chain triglycerides because it usually didn't absorb through the lymphatics. It goes through the portal circulation. So the patient should be kept on the medium chain because there's two types of small chain, medium chain, and long chain triglycerides. So you have to advise the medium chain triglycerides containing food.
All cases you may not need to give total parenteral nutrition. If the patient is an enteral alimentation, continue oral. And as Dr. Hug says, in those patients, you have to substitute with medium chain triglycerides. Right?
Yes, yes, yes. Sir. One more question. Is there any difference of doing the split technique first on the Caval side or first on the aortic side?
So choosing the template for the surgery is very important. However, if we choose to do the split over the aorta first, the benefit is that we can identify a right-sided lower polar renal vessel and preserve it. And doing the split on the IVC first will help us to properly define the sympathetic trunk chain early in course of the surgery and preserve it.
Good,
So
good.
these are the two main benefits.
Good. Good.
So what happens if you do not do a nerve sparing RPLNA? What are the complications of not doing a nerve sparing?
Sir, if we don't do a nerve sparing or if we injure the nerves, the major complications are with bladder and bowel habit and with erection and ejaculation process.
Ejaculatory dysfunction, retrograde ejaculation.
Any numbers, Shumantra, regarding the ejaculatory dysfunction without and with nerve sparing?
Nerve sparing, yeah.
I'm very sorry, I can't.
No problem. No problem.
Almost 80% without. And
yes, it's like about 90% will be without, and with nerve sparing about 98% can preserve their, at good centers, at high volume and experienced centers, about 98% can have a preserved ejaculation with the nerve sparing approach. Right.
The floor is open for any other residents or anybody else wants to ask any question to Dr. Shashank. Welcome.
For roll technique, which instrument was used? That it is a scoop?
They're asking which instrument was used for the.
I believe it was a hook. I believe it was a hook. Yes. And you should notice the diathermy tip also. It's as small as possible to prevent any injury to any nearby structures. And definitely it's kept on a low energy setting as well.
The right angle was used, I think. So
yes, yes. A right angle to lift the fascia. Yes.
Thank you, sir.
So I think we have a set of questions, an interesting quiz sort of thing for the residents. So we'll go to that and we'll wind up after that. So yeah. Is it still? Are my slides visible to everyone?
Yes, yes, they are visible.
Yes, sir.
So these are a few case scenarios in CO testis. Most of the points we have already discussed. I would invite the residents to answer so they can answer the questions. And if not, then our esteemed faculty is there who will be answering the questions. So the first question is, it's a 35-year-old male. Just a minute, let me clear this. Yeah, it's a 35-year-old male with left testicular mass with mixed GCT and orchidectomy and a history of right undescended testis that was brought down in the childhood. How would you evaluate and manage the right testis? So this, I think, students have already answered, but still. So anybody wants to answer this? How would you evaluate?
Any of the residents can answer.
Sumantra?
Yes, sir.
Yeah.
Sir, this testis has a high risk of malignant transformation as well because of two risk factors. One is that patient itself has a history of testicular tumor, and two, it has an undescended testis. So I would like to do an regular ultrasound of this testis to look for risk factors in this testis.
Age is also there, 35 year.
Yes, sir.
Less than 40 year age.
So less than 40 years. So these are the risk factors. As we already discussed, age less than 40, undescended testis,
Yes,
and
sir.
rightly you said you'll do an ultrasound and look for microlithiasis.
Yes.
And then you would need to do a contralateral testicular biopsy in this patient, contralateral inguinal testicular biopsy. If you find GCINS, then what do you do?
If I find GCIS, then I can give the patient an option of radiotherapy of 20 gray to the ipsilateral testis.
Or orchidectomy also is an option.
Or sorry, if the patient has completed family and is ready for orchidectomy, we can proceed with the most definitive procedure as well.
So I'll go to the next question. So this is about a 25-year-old male patient with a midline abdominal mass and normal markers. The mass was biopsied and found to have non-seminimatous germ cell tumor. On examination, both testes appear to be normal. What would you do? Just Abel-Hemos extragonadal germ cell tumor? Do an ultrasound, and if it is normal, only then Abel-Hemos extragonadal germ cell tumor. Do bilateral inguinal testicular biopsy, and if negative, only then Abel-Hemos extragonadal germ cell tumor. Identify if the abdominal mass conforms to the drainage area of right or left testis, and then do a unilateral inguinal orchidectomy. So, anybody else? Can Dr. Jayed answer this?
I'll identify if the abdominal mass conforms to the drainage of left testis and do a unilateral inguinal orchidectomy for that patient.
Okay. Any other answers?
Sir, for this patient, we have to consider two scenarios. One is the patient might have an extragonadal GCT, and two might have a burnt out testicular mass. So we have to look for extragonadal sites, and if the patient does not have an extragonadal site, then we label it as then we proceed with chemotherapy, and after chemotherapy, and then at a later date we can plan to do unilateral inguinal orchidectomy depending on the drainage pattern of the testis.
Yeah, in this patient, option 2 and option 4 both are right. Do an ultrasound of testis. If you find ultrasound is absolutely normal, you can label him extragonadal GCT. You have done the biopsy. You know that it's a NSGCT. Go ahead and do chemotherapy. But at the same time, this patient need to be followed up. You need to keep looking at the testis from time to time. And if there is any doubt, then you would have to do an orchidectomy at a later date. Option 4 lets you identify that if it is predominantly in the left drainage area or the right drainage area, then you have an inkling that this could be a left testicular burnt out tumor or a right testicular burnt out tumor. Right? When will you contemplate biopsy of this mass? In this patient, biopsy was already done. But suppose you have a midline abdominal mass with bilateral testis normal. Would you straight away do biopsy of the mass, or?
Sir, normal STM in the event of midline midline abdominal mass, we have to think of other pathologies as well. So lymphoma is a possibility. We will do a biopsy from the mass in that case.
Yes. So normal STM. STM is the key word. If STM is elevated, then you would need to do then you do not need to do a biopsy. Then you know that it's an NSGCT. But if STM is normal, then you need to do biopsy. Sometimes when you do biopsy, you find everything anaplastic looking. You are not able to make out. In that case, is there anything else that you can do?
Sir, we can proceed with an IHC for IHC of the biopsy tissue. So from the IHC markers, we can there is a possibility of getting down to a probable diagnosis of the primary malignancy.
Another thing that you can do is look at the short term of chromosome 12. That is isochromosome 12p. So I12p, if you find that, then more or less it's a ECP. Right? Can I go to the next question? Yeah. So this is the next question. In case of GCT, what is the CT size criteria? This we have already answered. Anybody? Dr. Jayed, can you answer this? Jai, you need to unmute yourself.
Option 4, sir. If it's more than 4 mm in the drainage area or more than 10 mm in other areas, sir.
Okay, so that was easy. So can you go on to the next question? So 27-year-old male with right testicular tumor post-orchidectomy, it is NSGCT, 1.8 centimeter para-aortic lymph nodes. Post-orchidectomy tumor markers are in S1 range. Next plan of management. NSGCT, S1 range, N1 lymph nodes.
We'll go for induction chemotherapy and then follow.
Yeah, so this is a good risk NSGCT. You would go for induction chemotherapy with these cycles. This is just kind of revision. Okay. So, what is the rationale of using a single agent carboplatin in treatment of clinical stage 1 seminoma? All of these are true except absence of teratoma in seminoma, less neurotoxicity compared with cisplatin, less nephrotoxicity compared with cisplatin, less ototoxicity compared with cisplatin, or similar efficacy to cisplatin.
5, sir. Similar efficacy to cisplatin.
Yeah, so that's the except answer. Why? Would you want to elaborate?
Carboplatin does not have similar efficacy to cisplatin shown in multiple studies. However, it does have a better toxicity profile compared to cisplatin, and teratomas are not addressed by chemotherapy.
This is something that we did not discuss. 45-year-old male with testicular mass and Jagger syndrome, gynecomasia. What is the likely diagnosis of this testicular mass?
This might
Leydig cell tumor.
No, it's a Sertoli cell.
This is a very entrance exam like question.
Yes. What is the most common non-PCT tumor in the testis? It's a Leydig cell tumor. Most common is the Leydig cell. Okay. According to IgCCG's risk classification, which of the following is indicator of poor prognosis in seminoma? Pulmonary gets non-pulmonary, LDH 10 times normal.
None of them.
None of them, because there is no poor risk in seminoma. IgCCG doesn't classify poor risk for seminoma. On that note, I would like to ask why mediastinum NSGCT is considered to be poor risk. Sumantra or Jayed or anybody else? Is that a Vishal?
Mediastinal primary is poor responsive to chemotherapy, and that's why, sir, it's not correlated with the tumor markers as good as NSGST. That's why, sir, follow-up and treatment of mediastinal primary is a bit difficult.
Yeah, so mediastinal primary is a poor risk because it doesn't respond well to chemotherapy. There is preponderance of yolk sac tumor there, so these are the only location where your yolk sac tumor could be there, and response is generally not that great. Okay, this we have already discussed. What is complete response? Sumantra.
Sir, complete response is residual masses. No. Sir, complete response is defined by complete resolution of the mass below 1 centimeter size and normal tumor markers. So it should be.
So it is number 2 is the answer.
2 is the answer. Sir.
So what is the management of a burnt out testicular primary, and why is it necessary to manage a burnt out testicular primary?
Sir, because the burnt out testicular primary might also be a site for further seeding of metastatic cells into the body. So after taking care of the metastatic lesion, it is important to identify the site of burnt out testis and do an orchidectomy of that.
Why? You have already given induction chemotherapy and salvage chemotherapy. Then why do you want to still remove it?
So there may be a component of teratoma present, which and at any point of time can turn into malignant and or other secondary malignancies and may present with
Yeah, so the
teratoma during
answer is what you said, Jay. Teratoma might be there. And also what Sumantra said, this can still be a site of viable tumor even after patient receives chemotherapy because of the blood testicular barrier. So the BTB is there, chemotherapy doesn't reach the testis easily. So that is why even after chemotherapy, the testis could be a safe harbor for this viable malignancy. So that is why you need to address this at some point. Last question, 55-year-old male with large testicular mass reveals spermatocytic GCP on high inguinal orchidectomy, markers are normal, what next?
Sir, only follow-ups.
Only orchidectomy is
the only malignant.
Because these are extremely rare that they can undergo sarcomatoid transformation and metastasis. Otherwise, this is purely a benign tumor. So no need to do anything. Yeah, I think so. We are done with this. So I'm going to stop share here. So any other doubts or anything else? I think our residents did a fantastic job. So I am extremely happy with our residents.
It was a wonderful session.
Yes.
So you just mentioned that there is a blood testis barrier for chemotherapy, but sir, for JCNIS, there is written that although the chances of recurrence is small, but chemotherapy can be given for JCNIS of the contralateral testis if it's
yes,
there.
chemotherapy is an option, but if you see the efficacy of chemotherapy is the least.
Yes.
Like radiotherapy works better, orchidectomy is the best option, partial if you can do that is also an option. Chemotherapy is the least best option or the least of the option. So highest chance of relapse is with chemotherapy because of this. The chemotherapy you cannot assure that you are going to achieve a complete clearance. Okay. Any other doubts? If not, then I would like to thank Eastern for giving me the opportunity. I'd like to thank my co-panelists, Dr. Shashank and Dr. Huck, who have done a fantastic job in getting the excellent video. Dr. Shashank and Dr. Huck has put in effort to get the case scenarios ready, and we had an excellent case discussion. It's a vast topic with very nuanced topic. I hope that we could clear some of the doubts. It was a refresher for me also, and I thank Eastern for this. I would like to hand over the mic to Dr. Ranjan Dev for his comments on this.
Yeah, thank you very much, Prashant. I am very happy that the way you, Shashank, and all the students have come today, it's very encouraging to see that our future is in a good hand. Both the teachers are very young and the students are growing, and all these things are really encouraging for me as a senior person in this fraternity to see your performance and the way you have covered the entire aspect with the depth you have entered. It is really enlightening for all the students. On behalf of the Zone Urological Society, I really extend my hearty congratulations to all of you and also the students for participating this and conducting this session. Thank you very much, both the teachers and the moderators and the students for participating in today's program. Next, we'll have our physical mock test next week. So get ready. We have given you enough opportunity for the last 4 weeks to get the major subject, excepting the beach and the bladder tumor. All major subject has been discussed in the short span of period. And after the mock test also, we'll have the rest of the topics so that before the examination, you will get a full revision of the course, what you need to study in this program. With this, I thank all of you, Prashant, once again for your excellent arrangement. Thank you very much.
Thank you, everyone.